उसामा चार्जिंग ऑन कीजिएगा, जल्दी से जल्दी 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 स्विच ऑन करें।
बिल्कुल एंड हो जाता है,
पता नहीं वो नहीं होगी ना चार्जिंग।
इधर से देख लेते हैं ना आपको।
नहीं नहीं यार, हौसला तो करना यार।
नहीं ये देखूंगा व्यू कितना कैसा है।
तो देखो
ओके नहीं किया ना आपने?
क्या होगा, नहीं लाइव है, लाइव पे क्लिक करो ना यार।
ये नहीं है लाइव।
एक सेकंड, ओहो पब्लिक करना है इसे। डन, सेव। अब रिफ्रेश करो,
ठीक है,
आ गया। ग्रुप 1 हो गया ना। ग्रुप 2, यार ये बहुत मसला है।
आप कैमरा से दूसरा लगाएं।
मुझे लगा लेता हूँ दूसरा कैमरा भी, कोई इशू नहीं।
ये देखें, व्यू नीचे से ऊपर आपको दे रहा है ना
वो
ऐसे।
ठीक है, वो अभी कोई इशू नहीं है इससे। Let me post it. We can also add another camera if you want. So I want everything to be fine and accurate, and I want a good to go button. Can you give me the camera, please? Open it up. Put this away. Put this away. Just give me a second. Virus. Let me see the result of this camera. We need to remove this. Let me post this on to share to Facebook and share to Instagram. Okay, everything is done. Now we can install this camera also and see how it works. Okay, so this will be done as a webcam. Here it is. I think we can have a video from this also. We need to click on to video capture device, webcam. This is Logitech 520. Okay, so HD webcam C525. Is it okay?
Yes. Clear view लेकिन इसमें देख
Which one is better?
ये ठीक है सर
Should I turn off the
Yeah.
laptop? नहीं, ये तो बड़ा है ना. I want you to tell me.
व्यू ये अच्छा है और
Really?
इसका क्लियर व्यू है
ये बड़े वाली लाइट ऑफ कर दो.
नहीं उसके साथ अच्छा है वैसे एक दफ़ा ऑफ करके देखो
हाँ, लाइट ऑफ करें. I think this is better now. This camera. The other should be turned off. Webcam should be, laptop camera should be turned off, and this should replace this. Now I think वो मैंने वहाँ पे बंद किया ना.
ये इसकी ना एक मिनट क्वालिटी
आवाज़ ऊंची करो ज़रा. आवाज़ भी आ रही है ठीक. Everything is fine. आवाज़ ऊंची करो ज़रा. आवाज़ भी आ रही है.
बेस्ट
Okay, so what do you say? Shall we start? Let me see the hosts. Okay, so you ready?
लाइव व्यूअर्स हो गए
Okay, that's nice. So हम कुछ देर में start करेंगे. We'll start in a few more minutes. Definitely we are waiting for our friends to join us, and a green signal from our friends also. Let's see if we can have another audio device from the laptop, from this camera. Meanwhile, we can audio input capture. How about Logitech audio? Okay, so yes, so yes, so, or how about this? Can you please tell me now? Can you listening to me? Is this audio is good or the previous audio was good? There must be some ads. This is happening with the YouTube. There must be some ads. Okay, is this audio correct? This is happening with the YouTube. There must be some ads. Okay, is this audio correct? It's fine. I think I should remove this, the other microphone,
यस सर
the wireless one. Maybe we need this when we are going to do the
Perform
practical
practical,
session. Yes. Let's turn it off, put it away, because we are using that as our audio source now. It is good. It's fine. Come on. This is so bad.
कमेंट्स आ रहे थे आप
Sorry. क्या कह रहे हैं?
सर प्रीवियस इज़ फाइन
Previous?
प्रीवियस वो माइक ये ठीक है ये पूछ
Ghazal Hussain, audible here.
ये भी है
And okay, if the audio is clear or not, you guys can tell me. I want you to keep it open like this so we can have.
कमेंट्स विजिबल
Okay, if the audio is clear or not, you guys can tell me. I want you to keep it open like this.
प्रीवियस ऑडियो इज़ फाइन
Previous audio is fine.
लगे ये
No, we need to see the other comments as well. Okay, let's not use this then. Let's turn this off and use the other audio device source. We do have to just plug it. It's not a big deal. Okay, let's not use this then. Okay, so I have switched the microphone on from your side, so good. Shall we start? You can turn off the audio if you want. I have switched the microphone.
ठीक है.
This is
ज़्यादा
better.
clear है.
Okay. Cannot take the- जी अस्सलाम वालेकुम. Okay, we will start formally by the name of Allah subhanahu wa ta'ala. Bismillahirrahmanirrahim. La hawla wa la quwwata illa billah. So thank you very much for joining me today. It is an honor, of course, to share my experience, my skills and my knowledge with all of you fellows from Pakistan, from abroad. So I welcome you all, and I'm very thankful to UMT. They have requested me to conduct this session for their MS students. So I've taken this opportunity to, use my YouTube platform to share this with all of you guys. So I wanted a bigger audience to see this and to get benefit from this session. So without further delay, let's start discussing what we are going to discuss today. And you already know that we are going to discuss introduction to thrust joint manipulation of the cervical spine. So in this lecture, we are going to discuss the core concepts, the indications, the contraindications, the techniques, and of course I'm going to demonstrate practically how to perform the thrust joint manipulation. And if you have any problem at any point of time, if you experience or encounter any problem like there is no audio or whatsoever, you can send me a WhatsApp message or you can call directly at my WhatsApp, so I'll be updated and definitely I can fix the issue. So because everything right now is perfect, but anything can go wrong. So let's start with today's session. Bismillahirrahmanirrahim. So today we are going to discuss the introduction to thrust joint manipulation of the cervical spine. I am Dr. Syed Hussain. I am a PhD in physiotherapy from Tehran University of Medical Sciences, currently serving as an assistant professor at Department of Rehabilitation Sciences, Shifat Amir Millat University, Islamabad, Pakistan. And right now I'm sitting in my clinic. My clinic is in Islamabad. So I want you to watch this video, and by the end of the session we'll try to watch it again and we will try to see what is wrong in this video. Okay, so this is just for the educational purposes. I have turned off the audio, so there is no copyright issue. So I want you to see it or watch it very carefully. So as you have seen in this video, people are trying to cavitate or manipulate the cervical spine of their patients, of their clients, but in a very inappropriate way. And what are the mistakes? I believe after the session you'll be knowing their mistakes and you can overcome your own mistakes if there is any. So what is exactly manipulation? Now manipulation is high velocity low amplitude thrust technique or high velocity low amplitude technique, It is also called as thrust manipulation or thrust joint manipulation. According to the grade Maitland school of thought of manual mobilization, it is grade 5. As well as for the Kelton one, it is considered to be grade 4. Chiropractors, they call it as adjustments, and sometime it is referred to mobilization with impulse, as well as it is called as high acceleration and low distance technique in osteopathy. So this is all the same technique from different school of thoughts. People call it differently with different names, so you don't get confused with this. So I've added these things. If we talk about history of manipulations, it is one of the oldest and most commonly used manipulative techniques, and it is practiced by a variety of healthcare professionals. Let's see some. So Hippocrates, in Urdu we call it Bukrat. I don't know about Arabic or Persian, but I know in Urdu we call Bukrat. So Bukrat, Hippocrates, the father of medicine, and he was about almost 2500 years ago. He wrote a book. The book was called as On Setting Joints by Leverage, in which he has shown the table how to use the spinal traction and how to cavitate the joint and so many other things. As well as he has talked about reduction of dislocated shoulders. It's osteopathy. Osteopathy, the founder of osteopathy was Andrew Taylor Still, and he founded the osteopathy in 1874. But in 1892, he founded the first school of osteopathy in Kirksville, Missouri in USA. So what exactly is osteopathy? Let us see. They believe in rule of the artery. Now, rule of artery, I really don't know what is meant by the rule of artery, because being a physical therapist I never came across anything like that. But they say if you manipulate the spine, it will restore the blood flow and restores the body's innate healing ability. So if you read about the Greek mythology, you will see that there are two gods considered as Asclepios, and the daughter is called as Hygeia. So Asclepios is the one who is holding the cane with two snakes around it. So the believers of Asclepios, they believe that healing cannot be achieved innately, so it can be acquired, whereas the believers of Hygeia, they believe that the body has an innate ability to heal itself. So yes, to some extent the current scientific knowledge is very much aligned to the philosophy of Hygeia. You can read more about it if you are interested in Greek mythology. And the good thing is that osteopaths are currently licensed to practice medicine in all states of US. I don't know what are the legal requirements, but they are licensed to work. Then it is surprising to know that A.T. Still's student, one of his student, whose name was Daniel David Palmer, referred to as D.D. Palmer, he has been trained by A.T. Still for about 6 to 8 weeks, and in those 6 to 8 weeks he has developed his own school of thought that was called as chiropractic. So you can say chiropractors are basically, they stemmed from the osteopathy. And this is really very good to tell you right now that there was this guy whose name was Lily Howard. Now Lily Howard has lost his hearing because of some accident or whatsoever, and this D.D. Palmer has adjusted his spine, to which it was a miracle, not less than a miracle actually, that the man has restored his lost hearing. So then there was the formation of chiropractic. So they believe in the law of the nerve, which is very much, you can say, it is close to the philosophy of the physical therapy, but not really the philosophy of physical therapy. But it is very close or near to it. He also wrote the book which is called as The Chiropractor's Adjuster. You can download it. And he said that there are some subluxations and they restore the nerve flow or the flow of energy in the nerve to facilitate the body's innate ability. Chiropractors, they do not manipulate. They do not use the process of manipulating, rather they adjust. So they use this term which is called as adjusting. Then these are some famous physical therapists who actually advanced the practice of manipulation. And before we really continue, I want to see if there is any problem or not. So everything is audible, clear to you guys? Can we get a response from you guys on messages? Okay, so here we can see Freddie Maximiliano Calton-Bon. He was basically the first physical therapist amongst the first physical therapists who has talked about the concept of osteokinematics and orthokinematics. So he had a Nordic approach, or from Norwegian region. He has this approach, and he was the first one who related the manipulation to orthokinematics, like the bone movements and the joint movements. So similarly, Jeffrey Maitland, who wrote the book Vertebral Manipulation in the year 1964, and he talked about reproducible sign, currently called as the chief complaint or present complaint or major problem of the patient. Similarly, Stanley Paris, who is considered to be the founding member of American Association of Orthopedic Manipulative Physical Therapists, and he was also the first president of AAOMPT. So then this is very interesting to know that Dr. James Syed, sometimes referred to as CDX, or he's considered to be the father of orthopedic medicine. Just like orthopedic surgery, we do have a branch of orthopedic which is called as orthopedic medicine. So he is considered to be the father of orthopedic medicine. His father and mother were both doctors, and he was from Great Britain. So he taught in a lot of universities and institutions, and according to him, physical therapists were the most appropriate professionals to learn manipulative techniques, because if you read about the orthopedic medicine, there are three things. They talk about cavitation or joint manipulation, they talk about joint infiltration, and they do talk about the deep friction or soft tissue mobilization. So there are three things in orthopedic medicine, and you can read more about it in James Syed's book, because you will see that the physical therapy profession has been influenced by Syed and so many other professionals, and they have taken a lot of information from other school of thoughts and created their own school of thought. So current scenario, no one profession invented or owns manipulation. Traditional chiropractic or osteopathy is based on unproven theories like the law of nerve, the law of artery or subluxation theory. And manipulation has been a vital part of the scope of physical therapy practice since the inception of this profession. These are some books. You can see this is Manual Physical Therapy of the Spine, and we cannot get the pointer option here. Okay, so Manual Physical Therapy of the Spine as well as Traction Manipulation. This is volume 3 from Freddie Maximiliano Calton-Bon. So this is also available. You can download these books very easily for free from internet, and you can learn these techniques in a way much advanced fashion. Okay, so what is the difference between mobilization and manipulation? Cavitation, the popping sound, it distinguishes a manipulation from a mobilization. Okay, so popping or crackling sound. So according to some authors, mobilization can be stopped by the patient, whereas the patient cannot stop manipulation because it's quick and it is so brief. It was Hippocrates who said that look well to the spine for the cause of disease. I'm going to give you one thought. You can say it's going to be food for your thought actually. So I'll not discuss more than this, that if there is a problem in the viscera, can we or cannot, like I'm just asking, I'm posing it to you, so I'm letting you to decide and read more about it. Can we or we not fix the functioning or augment the functioning of the viscera by adjusting the spine? Because adjacent to the cervical spine, thoracic spine, sorry, adjacent to the thoracic spine, we do have some chain of ganglias, and these chain of ganglias are sympathetic chain of ganglias. So can we affect the presynaptic neurons, and then can we affect the postsynaptic neurons, or can we affect the visceras directly or indirectly? You can read more about it, but just one hint for you guys, that if there is a problem in the gastrointestinal tract, you will always find hypomobility or restriction in motion between T6 and T12. So go and read more about it. Okay, so we do have some, let's talk more specific about the cervical spine. We have typical vertebrae and we have atypical vertebrae. So let's first define what is a typical vertebra, and after that every vertebra is going to be atypical. So a typical vertebra must have a vertebral body. Okay, so if there is no vertebral body, then the vertebra is considered to be atypical vertebra. Okay, then a spinous process, transverse processes should be 2, then there will be superior and inferior articular processes, and then there will be 2 pedicles, 2 laminas, right and left, and that's all. So a neural foramen as well. So all these, if they are present in a vertebra, is called as a typical vertebra. Okay, so I'm going to show you guys, if we can, let's say let's discuss it from here. So this is vertebral body, the spinous process, these 2 are the transverse processes, these are the laminas, and these are the pedicles and the neural foramina. So if and then you, on the side view, you can see the superior articular facets and inferior articular facets. The cervical have their own characteristic features, the thoracic have their own characteristic features, as well as the lumbar vertebrae, they also have their own characteristic features. Sorry for the slippage of tongue. So then we have the atypical vertebrae. Now the atypical vertebrae are actually those vertebrae which either have an additional process or appendage, or if they are lacking process. For example, in Atlas C1, you see there is no vertebral body. There is an anterior arch, there is a posterior arch, 2 lateral masses, and transverse process. So this is atypical because it does not have a vertebral body, it does not have a spinous process. This is very important. No vertebral body, no spinous process. Then from C2, which is called as axis, axis like point of rotation. So axis, it has one teeth like or peg like process, which is called as odontide process or dense process. So because of this, it is also considered to be an atypical vertebra because it has an additive feature which is not in a typical vertebra. Then in the C7, the C7 is called as vertebra prominence. Prominence means which is very prominent or which is very easy to identify. So C7 is the vertebra prominence because of the longest spinous process, and it is also called as atypical vertebra. So anywhere between C3 to C6 we will call as these are the typical vertebrae. And one more classification I'm going to discuss is that upper cervical spine and lower cervical spine. So C0, C1 and C2, these 3 are called as the upper cervical spine. C3, 4, 5, 6 and 7, these are called as lower cervical spine. I hope everything is clear, audible and okay from my side and from your side also. Yes? Now we can see these are the cervical vertebrae, and this is very interesting. The cervical vertebrae have a foramen which is called as foramina transversaria, okay, or transverse foramen. It is basically a passage for the vertebral artery, and we can see the vertebrae, they have this artery which is vertebral artery. Okay, let me correct that. Yes, that's fine. Okay, so the foramina transversaria has the passage of this is fine, maybe, yeah, the passage of vertebral artery. Sorry for this disturbance. And then they do have these uncinate processes. These are called as uncinate processes. Okay, which are spike like this and this. Here you can see the subclavian artery is giving rise to the vertebral artery, and this vertebral artery is making the basilar artery. So it is the continuation of a same artery from the subclavian artery to the cranium, to the basilar artery. So sometime it is called as vertebro-basilar artery, and now you can see in the green color the foramina transverse area through which the vertebral artery is passing. We know that something is called as motion segment or Jungen's functional segment. Motion segment is two adjacent vertebrae and all the soft tissues between them are called as a motion segment. So a motion segment typically has at least two joints, three joints. One is called as the symphysial joint, the intervertebral body joint, and the two facet joints. So collectively three joints at a single motion segment. Now the first activity that I want to do is, I will write it down, but I'll not do it right now because we will spare all the activities for the last, because I just want to finish with the lectures and then we can go to the practical session. So we will write it that first activity is the palpation of spinous process and transverse processes of the cervical spine. You can write on the paper, please. Yes, take a pen. Okay, so palpation of the spinous process and transverse processes of the cervical spine. Like we have discussed already, in a motion segment there are joints, and these joints are actually symphysial joint and diarthrodial joints. So the facet joints are the diarthrodial or freely movable joint, whereas the symphysial joint are the intervertebral disc joint, and these joints are actually, permitting the movements. And let me tell you a fact that the facet joints, they act as a guide, just like the railway tracks, the rail tracks. So wherever the tracks go, the train goes to that side. So just like the railway tracks or the guides, the facet joints, they also guide the movement, and they can limit the movement also because of their angles of orientation. And there are actually 37 joints in the cervical spine, and 7 are actually these are called as false joints or pseudo joints, pseudo articulations. Okay, so they are like you can say with the ligament and with the vertebra. So ligamento-vertebral joint or osteoligamentous joints, we are not going to consider them the joint right now. But apart from that, we do have a total of 30 joints in the cervical spine. So the more number of joints we have, there are more chances to have a meniscoid entrapment. Maybe this is a new term for you guys, but simply put, just like our tongue is sandwiched or is sometimes it gets stuck between our teeth or chewed between the teeth, similar to that, the joint capsule can become inside the joint, go inside the joint, and then it can be compressed, which is called as meniscoid entrapment. So this is called as meniscoid entrapment, part of the meniscus or joint capsule when gets entrapped. And secondly, in our language we call it as chuk pad jana, okay, in Urdu. And then sometime they say that okay, it's neck lock or back lock. So this is the same thing. Okay, now we have these ligaments of the spine. The only function of the ligament of spine is to provide stability, and one important function which is of ligamentum flavum is to add pretension. Let's not discuss that, but let's go to discuss the other. So anterior longitudinal ligament, posterior longitudinal ligament, supraspinous ligament, interspinous ligament, intertransverse ligament, and the yellow ligament. Now this ligamentum flavum is the only ligament in the body that can be stretched up to 200% of its resting length. This is a fact. Okay, so it is the only ligament in the body that can be stretched up to 200% of its resting length. What is it means? It means if it is, let's say, 5 centimeter, if it is 5 centimeter, it can be stretched up to 10 centimeter. Okay, I believe you have an idea of where the ligaments are. So let's see if we can find. So anterior to the vertebral body, anterior longitudinal ligament. Posterior to the vertebral body, posterior longitudinal ligament. On the spinous processes, supraspinous ligament. Between the spinous processes, interspinous ligament. Between the two transverse processes, intertransverse ligament. And then between the pedicles of two adjacent vertebrae is the ligamentum flavum. Now these are the functions of some structures like vertebral body. In a normal spine, it carries 60% of the weight, and the facets, they carry about 30% of the weight, and the muscles, they contribute in 10% of the weight bearing. This is in a healthy and normal spine. But what happens if the curves are lost? What happens when there is myospasm? What happens if there is a forward head posture? Of course, all of these, they tend to change the dynamics of the spine, or sometimes referred to as vertebral motion dynamics. Here is the nucleus, and the nucleus, as we all know, is filled with water and proteoglycans. Now these these make the nucleus hydrated, and because of this, there is one law that is applicable to the healthy intervertebral discs, and that is, it says that the pressure liquid is equally distributed in all directions. It's Pascal's principle or Pascal's law, that the pressure in liquid is equally distributed in all directions. Here you can see that the nucleus is trying to hold up the compressive forces as well as it is pressing on all sides, and definitely if there is osteopenia, osteoporosis or things like that, then there can be problems. Okay, we have these curves, and these are primary and secondary curves. The curves that are present at birth are called as primary, and the curves that are present acquired after birth are called as the secondary curves. So they are acquired with neck holding and standing, and sometime walking also. Here we can see, so like I was discussing, what happens to the weight distribution or vertebral motion dynamics if there is a problem in the curvature, if there is a problem in the posture. So here we can see that it gets disturbed with these things. So the motions can be flexion, extension, side bending, rotation on both sides, and then we can have coupled or non-coupled motions as well, which are actually combined movements, and we are going to discuss that also. For the upper cervical spine, we have coupled motion, which is called as type 1. Type 1 is when side bending is coupled with rotation to the opposite side. So for convenience, you need to remember the function of sternocleidomastoid, side bending to one side with rotation to the opposite side. This is called as the coupled motion of upper cervical spine. And for the lower cervical spine, it is side bending to one side with rotation to the same side. It is called as type 2 mechanics or type 2 coupled motion. So the reverse of this is called as the non-coupled movement. Now the coupled movements are those movements which, when performed, they result in greater ease of movement and greater range of motion or movement. So two facts, greater range of motion and greater ease of movement or motion, is called as coupled movement. And for the non-coupled motions or movements, these are the movements which are, when combined, they result in less ease of movement or sometimes difficulty in movement, and they also result in restricted range of motion. So we use the coupled movements for facilitation of the motions in hypomobile segments, and we want to restrict the hypermobile segments using the non-coupled motions, as well as when we want to lock the joint physiologically before cavitation, we will use the non-coupled motions or movements just to lock the joints. Now these are the angles of orientation for the facet joints. For the cervical spine, it is very simple to remember. If you draw a line from the cervical spine to your eyes, it will make 45 degrees angle, and that is against the horizontal. So if you draw a line and you make an angle that makes a 45 degrees angle, so this is the angle of orientation for the cervical spine. So why it is important? Because they they guide the movement and they can be used to cavitate. If you try to cavitate a joint outside its limits, then there will be problem. And for the thoracic, again the same formula, try to draw a line from the thoracic spine towards your eyeballs or the lateral margin of the eye, that makes 60 degrees, and from the lumbar it makes 90 degrees. Muscles of the spine can be classified into local muscles or the global muscles. The local muscles are called as the small muscles. These are actually the muscles that are unisegmental, whereas the global muscles, they are multisegmental and they are responsible for gross movement, whereas the core muscles, they are responsible for the fine or very accurate movements. And always treat the muscles first, then the vertebrae. Why? Because whenever there is muscle contraction, can you show me the model? Whenever there is the vertebral model, the next what happens, I want to show you. Let's say this is a motion segment. Okay, so what happens when the muscles, they become tight, they become tight, they are going to cause a compression. They are going to cause a compression like this. Okay, just like this. So if there is a compression like this, it leads to, normally the vertebrae are like this, spaced, and whenever there is myospasm, it results in decrease in space, just like this, being pressed. So when this is happening, it adds more pressure to the body and it adds more pressure to the spine. So if you are not going to fix the muscles first, if you are not going to relax the muscles, it means that you are not treating the patient accordingly, and there are more compressive forces. We never want to manipulate in a patient whose muscles are tight or in spasm, because it restricts the range of motion and it restricts the drive that we want to do. Now and feel is, we can say, at the very end of the motion, we want to test what structure is causing the stoppage of range of motion. Okay, so which structure is responsible for the stop? So in the cervical spine, you can see for the flexion it is firm, for extension it is firm, rotation and side bending it is firm in all direction. Why it is firm in all direction? Because of the ligaments. For the flexion, the nuchal ligament, which is actually the supraspinous ligament, it is the flattened part of the supraspinous ligament. For the extension, the anterior longitudinal ligament. For the side bendings, it is the intertransverse ligament, and for the rotation, it is the alar ligament that is responsible for the limitation. Then we can have osteokinematics and arthrokinematics. Osteo refers to bones. So the motions of the bones or the movements of the bone, like flexion and extension, is osteokinematic, and arthrokinematic is roll, spin and glide. So how does the vertebra go into flexion and extension? Let me demonstrate it to you guys so you can have a better understanding, and you should know that some things are prerequisite for the other. For example, it's just like this, that let's say we have 10 stairs. So I cannot step from the ground to stair 10 exactly. I need stair 1, stair 2, stair 3, stair 4. So I need to keep on moving. So similarly, if the vertebra is not moving at all, if it is ankylosed, you cannot go into cavitation, you cannot go to manipulate the joint. So you need to create some mobility before you cavitate the joint. If you are not going to create the mobility, you are going to definitely cause some damage. So I want you to understand and see this, how the flexion occurs. The flexion is not like this, it's not just going up and down. It goes anteriorly first. There is anterior slide, there is this anterior slide. Okay, slide and glide. So glide is actually when it is produced passively for therapeutic purposes, it is called as glide. It is the same phenomena. And slide is physiological phenomena. Okay, it is happening within the body automatically. So how does the flexion occurs? First there is anterior slide and then rotation or roll. So anterior slide and then roll, anterior slide and roll. It keeps on going like this. Extension, there is posterior slide and extension. So posterior slide and extension, posterior slide and extension. That's how extension is happening. Similarly, it is True for the side bending and rotations also. So if you are not going to mobilize the spine and the spine is not mobile enough to permit you for the thrust, definitely you can cause some problem. So we have already discussed coupled motions, type 1 for the upper cervical spine and type 2 for the lower cervical spine is coupled, and non-coupled is type 2 for the upper cervical spine and type 1 for the lower cervical spine. Then open back position. What is an open back position? An open back position is a position in which the joints are maximally apart. They are resting idly. So there is least amount of compression onto the joint. The joint is at rest and all the periarticular structures are relaxed. So this is called as open back position. In the open back position, there is another position which is called as resting position, in which these phenomena are occurring maximally. Some people, they say it's one and the same thing. Then we have a closed back position in which the bony surfaces are maximally congruent, in contact with each other, joint is most stable and the periarticular structures are maximally taut. So that's closed back position. Then we have another position which is called as actual resting position. You can say this is the open back position of a pathological joint or of a patient. Okay. Now just remember any school of thought, be it the Maitland, be it the Mulligan, be it Mackenzie, whosoever, all of them, they follow the Kaltenborn's principle of treatment plane. So it lies onto the concave bony partner. Okay, concave bony partner, and it is at right angle to the convex bony partner. That's simple. If you draw a line from the convex bony partner's midline, you know, it's going to be a right angle just like this, as you can see. So it's just for your understanding, because we use these treatment planes. So what I mean actually, and what is the role of the treatment plane, just try to understand this. I'm going to demonstrate with my hands. Let's assume that this is a convex bony partner. I believe you guys can see. I need to move over here. Yeah, that's fine. So this is a convex bony partner and this is a concave bony partner. If the concave bony partner is like this, you can move it like this. Yes, it's called mobilization. You cannot move it like this for mobilization. This will become distraction and compression, distraction and compression. This is going to be mobilization, right? So if it is like this, now you see it's going to move like this. If it is like this, it's going to move like this. If it is like this, it's going to move like this. So the treatment plane, according to the treatment plane, you change the direction of the force and it keeps on moving with the concave bony partner. Okay, so if the joint is like this, it can permit you movement like this. If the joint is like this, it can permit you movement like this. From here, it is different. So you see, every single aspect or phenomena is really very important. So this is all that is shown over here, that it keeps on moving with the concave bony partner. It does not move with the convex bony partner. Now we can assess the quality or quantity of the movement. Quality can be assessed definitely with the hands, but the quantity can be measured with goniometer, a ruler and other devices. And similarly, you can also test the mobility using manual grading system. So let's take this model and let's discuss. So if you guys can see, if I want to move this, let's say here, I think this is better, like this, it's moving. Okay, so let's say I'm trying to move it and it's not moving at all. It is ankylosed, no movement at all. If there is just slight movement, then it's grade 1. If it is a bit more than that, it's grade 2. And if it is normal, it is grade 3. But what if it goes more than normal, it becomes grade 4. If it is even more than normal, it is grade 5. And if it is completely unstable, then it is out of normal range and it's considered as grade 6. So we can assess. One test that is used to assess this is called as springing test. Springing, okay, in which what happens, the patient lies on their tummy, okay, on their stomach, and you press onto the vertebrae, spines processes upside down, one by one or collectively, and this is called as the springing test. Okay. So we can have hypomobility and hypermobility as well. Now please try to understand this. A joint can be hypermobile in one direction as well as hypermobile in the other, and you must always treat hypomobility or hypermobility if they are pathological, means they are associated with symptoms, and if there is a pathological end field. I want you to tell me if everything is fine. Okay, let's take a 5 minutes break and we'll continue from here. I'm turning off my mic. Okay, we are back again. So let's continue from where we have left. So these are the components of screening examination. I'll switch it to a very fast mode now. So history inspection, active movements followed by the passive movements, then resistant movements, symptom localization, superficial palpation, then of course testing the passive joint and soft tissue movements, and neurological and vascular examination. And after all these, you can have a better idea or understanding if your patient needs manipulation or not. So the two indications for mobilization and manipulation are pain and hypomobility, and please do not mobilize if the end feel is hard, and do not manipulate. Now this is somewhat conceptual, so I want you to understand this and pay more attention. So let's assume that if there is a joint and definitely in a joint there is a start of range of motion and there is an end range of motion. So from here to the yellow line, this is, let's say, for the shoulder or for any joint, let's say for the shoulder flexion, we can have from 0 degree to 180 degree. So if it is limited before, let's say at 90 degree, it is called as pathological barrier. So then at the end of active movement, if you try to move it passively, there is another space which is called as paraphysiological space, and you reach to a point where it is called as anatomical barrier. Okay, so we have these joints of grades of joint mobilization of Kelton-Mon, grade 1, 2, 3, and this is grade 4. So in grade 4 we want to move the pathological barrier towards the physiological barrier, but keeping short of the physiological barrier. For the Maitland we want to do the same, but this is now termed as grade 5. So Kelton-Mon says manipulation is best for extra-articular and intra-articular restrictions. Extra-articular restrictions that are lodged within the joint only, and the intra-articular which are already in the joint. Okay. Now these are the contraindications. We can have absolute contraindications. You would not use manipulation if it is an absolute contraindication, and relative when you need some care. So absolute for the bone if there is tumor, infection, metabolic changes, congenital, iatrogenic and inflammatory or traumatic causes. For the neurological, if there are cervical myelopathy, cord compression, cord equina, or nerve root compression with increasing neurological deficit. Then we have vascular, which in a person, if it is diagnosed with cervical arterial dysfunction, this is called as vertebrobasal artery insufficiency as well. Aortic aneurysms, bleeding, diathesis or severe hemophilia, and then we have others. For example, if there is lack of diagnosis, lack of patient consent, and the patient position cannot be achieved because of pain or resistance, so you do not cavitate. Okay. Relative is when if there is an adverse reaction to previous manual therapy session, disc herniation, prolapse, pregnancy, spondylolysis, spondylolisthesis, osteoporosis, and anticoagulant or long-time corticosteroid use. Then they can be advanced degenerative joint disease or disc disease. So in these there is relative contraindication, and in vertigo, as well as if there is psychological dependence and if there is ligamentous laxity. Indications are hypomobility and motion restriction, joint fixation, acute joint locking, restore bony alignment, meniscoid entrapment, adhesions, disc fragment displacement, pain modulation, reflex relaxation of the muscles, as well as reprogramming of the central nervous system and release of endorphins, and as a clinical prediction rule. So indications: range of motion restriction and pain modulation and reflex changes, neuroendocrine effects, clinical prediction rules. How to decide clinically: exclude the red flags, determine the influence of yellow flags, as well as try to identify the presence of a treatable lesion, which is called as somatic dysfunction. And I believe most of you already know about these things. So calculate risks and benefits and always compare or try and select upon the most appropriate or best intervention. So, and definitely if there is a patient preference. These are complications that can happen from cervical manipulation or manipulation to the spinals any region of the spine, thoracic or lumbar as well. There can be transient, which are short-lived. Then there can be substantive, reversible and non-reversible, and then there can be serious non-reversible events that can happen. So for the transient, they are common. They can start from 4 hours to 24 hours, but not longer than that, and most common is worsening of the patient's symptoms. Then these can be local discomfort or pain, headaches, tiredness and fatigue, radiating pain or discomfort, paresthesias, which are abnormal sensations, dizziness, as well as nausea and stiffness, and hot skin can be there. Then these are reversible as well as non-reversible. You can cause disc herniation or prolapse. You can cause nerve root compression, fractures and regional strains as well. Then substantial, these are serious non-reversible, okay. These are serious non-reversible. CVA, you can cause CVA, you can cause spinal cord compression, and you can also cause cardiac vena syndrome. Now, according to Peter Gibbons and Philip Tehan, whom are considered to be one of the best in the manual therapy or manipulation of the spine, so they have written some interesting books and manuals and videos. Their courses are also available on MedBridge, you can find, and they say that we should see these complications in the context of other adverse effects that are documented for the other treatments. Like, for example, exercise can induce myocardial infarction, cryotherapy and thermotherapy can cause burn, NSAIDs, they can cause gastric complications, and injection therapy, they can cause allergic reactions and sometimes infection as well. So it is of course up to the clinician to maintain a level of competence. So causes of complications can be lack of awareness of possible complication. You really don't know about what can go wrong. Then you can make a wrong diagnosis, inadequate palpatory assessment, lack of patient consent, and poor technique. For the poor technique, either it can be excessive force, excessive amplitude, excessive leverage, inappropriate combination of levers, incorrect plane of thrust, and poor patient positioning. I want to talk about this because I want you to understand one thing very importantly. If you look about C2 and C1 to this, the rotation of the spine is happening at this particular point. Or if I ask you the question, what is the function of C1 and C2? Atlantoaxial joint. It is like this, and there is a ring, and your whole neck moves around 70% of your rotation. It is happening to that joint. Now, this is important to understand that if you are going to just rotate someone's head like that we have seen previously in the video, you can definitely cause problems with the vertebral artery. And what is meant by the leverage? There are actually 3 planes, and there are movements of flexion and extension, side bending and rotation. So x, y and z axis. Okay, so x, y and z axis, I don't know if you know about these things. If you already know, you can tell me. If you don't know, you can tell me also. Yes, I can understand this. So here you can see this. If I put my hand like this, oh sorry, it's like this, okay. So this is actually x-axis. The movement of flexion and extension goes around this flexion and extension. This is y-axis. This thumb is y-axis. The movement of rotation goes around y-axis, and this is z-axis. The movement of side bending goes like this. So what is meant by the leverage? The leverage is a simple concept in the physics. You have already known about this. What is lever? Lever is a rigid bar that is used to, as a machine that is used to carry or lift heavy loads. So let me demonstrate you something. Oh my god. So there is a fulcrum. Okay, there is a fulcrum, there is an effort end, and there is a load end. Yes. So when we try to cavitate the joint or the spine, we can take one movement or one leverage. One leverage means, let's say, rotation, as you have seen. So this is only one lever. You are using one lever. Okay, rotation, the movement of rotation as your lever. Then what happens if you add side bending? What happens if you add flexion and extension? So there are some laws, and I want you to know more about these laws before we really proceed to how to do the thrust joint manipulation. Let's see. We know already the facet joints or their angle of orientation. We already know the open pack position of the spine. We already know the closed pack position of the spine, and couple motions and non-couple motions and Freud's laws. These are three laws. These are very important. The first law is actually called as type 1 mechanics, which we already discussed. Side bending to one side is coupled with rotation to the opposite side. The first law. The second law states that side bending and rotation are coupled to the same side, which is the coupled motion of the lower cervical spine. And then we have another law which is called as the third law. Now this third law is really very important. It says if the motion is introduced in one plane, then the motion of the remaining two planes is reduced. I want you to try it practically. I want you to try this with me practically so you can have a better idea of this third law. So because of this third law, you can have a better hands-on skills and you can make use of combination of levers and you can stay short of the complications. Now what I mean, if we perform, let's say, let me perform the movement of rotation first. So if I rotate, I can easily see my shoulder onto both sides. This is purely single movement. But what happens if I add full flexion? Now I cannot. See? So if I have introduced motion or movement in one plane, the remaining two planes motion will be reduced. So first movement will be called as first lever or primary lever. Second movement will be called as secondary lever, and the third movement will be called as tertiary lever. So what I mean is, greatest movement in the first lever is possible, then a bit less movement is possible in the second lever, and the smallest amount of movement is possible in the third lever. So we already know the barrier concept and rule of superior motion vertebral motion. That means that whenever we talk about the movement of the superior vertebra. Put it silent. We talk about the movement of the superior vertebra, not the inferior vertebra. And rule of vertebral body motion, we want to see what is happening to the body, not the spine's process or transverse process. And how to find a lesion in the spine and how to deliver a thrust, we will definitely discuss it in the practical session. So open back position for the spine is slight flexion and closed back position for the spine is extension. So we already discussed these laws. Okay, everything is fine, I believe. So start. What is a lesion actually? We call it as start. So start is actually S stand for symptom reproduction. The patient is going to tell you, okay, this is exactly what I was suffering from. This is exactly my pain. So T, it relates to the tenderness of the tissue. So if you are going to palpate, the tissue is going to be tender. Then A relates to the asymmetry. So one tissue will be very tight and taut and the other will not be, and then you can see spasm on one side and no spasm on the other side, as well as R stands for the range of motion. You will find the restriction in range of motion, and T definitely in the tissue texture you will find changes. So you can look for the temperature change, you can look for the tone change, you can look for the overall appearance change, color change, and movement restrictions, and these things, they collectively help you find a start lesion. Important, always diagnose, localize the segments to be treated, control the areas so the patient is in comfortable position to the restrictive barrier, okay, to the edge, not the wall, and use releasing maneuvers like muscle energy technique, patient's breathing or jaw clenching or relaxing or some other thing. And when confident that the patient is relaxed and not guarded, add a rapid accelerating thrust within the articulatory plane or planes of the joint with total movement kept to the absolute minimum. Okay, so we want to keep the movement limited, very small, very short, but it needs to be very robust, very fast, but it has to be overall a small movement. So here you can see we are about ending this lecture in a few more slides. So here you can see what is happening to the vertebral artery through rotation. Rule of superior vertebral motion is when we talk about this, what is happening to the superior vertebra in the flexion. The flexion of the spine initiates from top to bottom, not bottom to top. So if we talk about a motion segment L4, L5 or C3, C4 or T1, T2, whatsoever is the motion segment, we always talk about what is the position of the upper vertebra in relation to the lower vertebra in that motion segment. Okay, so we will definitely go and discuss in detail in practical session as well. So here you can see what is happening if someone is rotating their neck maximally. You see there is tension or there is a stretch onto the vertebral artery. So this can lead to problems. This can lead to the dissection of this vertebral artery. That can lead to stroke, and that can even lead to death. Here the same phenomena is shown. If you if you rotate it more, you can see over here that the vertebral artery, it becomes occluded and it becomes stretched, and sometimes it can be broken down. So these are the references. You can yeah, so you can read these books, and you can have more and deeper idea or understanding about the concepts that I'm going to discuss practically. These are the links. You can contact me at my WhatsApp, you can visit my YouTube channel, and you can go to see my website. I definitely have plans to write more blogs and things about manual therapy, physical therapy on my website. You will find definitely there are a lot of useful links. You can say some blogs are really very good. I really enjoy writing if I have time. So you can read about a few blogs which are really very good. I recommend you to visit my websites. And that's all from my side. If you have any questions and comments, do let me know. And after 5 minutes we are going to start the practical session, because I have to change the camera, and I want to change the view of this screen. So for the practical session you will be seeing just the camera showing you everything. So I need a few minutes to adjust everything, and then we'll come back. Okay, so right now we are taking the break just to set up the things, and in a matter of 4 to 5 minutes we'll continue. Okay. Okay, so let's jump to the practical session and let's see what can we do as a physical therapist to assess number one. And definitely it requires some patience, it requires some efforts and practical. So I'll be turning off my this camera, you will not be seeing me, you'll be seeing me on that big camera. So let's see, let me turn this off. It's going to get blank a bit. I want to stay updated also. So let's see. Okay, let's assume that we have this patient and we want to assess the cervical spine for somatic dysfunction and we want to manipulate. Okay, so I request Dr. Sama to please can you sit here. Okay, so this is let's say this is the neutral position of his spine, and the first thing that we need to do is to look for his overall position. So from the side view we want to see his craniovertebral angle, so whether he is in the forward head position or not. So right now you can draw this line and then you can draw this line and you can add a goniometer to see if it is more than or less than 45 degrees. So to me, it seems nice and normal. So after that, you can ask your patient to perform the movement of flexion and extension. So let's perform the movement of flexion and go into extension. We can ask about the restriction in motion and we can ask about the pain. So for the flexion, I want you to focus on these things, that whenever he's going to perform the movement of flexion, I want you to see the movement. It starts from top and goes to the bottom. So can you please repeat it in a slow way? Yeah, 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 all the way. That's it. And come back. So you will see on in extension is upper cervical spine moves in the last. So you can ask if there's any pain or patient or not, and then you can of course perform these passive movements. For the side bending and rotation, you can ask the patient to look to right side as well as to the left side. Here you don't do anything at all, you just want to see the overall range of motion and try to side bend to the right and left both sides. And you can see, for example, if I ask him to turn this way, can you perform the side bending? Now you see his shoulders getting up. So it can be an indication of tight upper trapezius muscle fibers. So we definitely need to work on these as well. Go to this, and same is happening to this side. Okay. Then we can perform these movements passively, and then we can jump to the palpation. The first spinous process that we can find, let's if you move your hand from top to bottom, you will see there is a protuberance which is called as external occipital protuberance. Okay, this is a point. So from there you go down, 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 and you go deep. So meanwhile, more of the students are going to join us. Let me find a few more devices that we can show. So we are just waiting for the other students to join us, and we have halted the session because we want the other students to be part of the session. Okay, it can be quite difficult sometimes to manage these things. I believe. Sorry, but it's okay. Where is the battery? I don't see the battery. No. It's not the tens. It's algometer. Dr. Noshin, can you please start now? Okay, we are starting. You gave us time, so definitely we want to show your students some real good stuff. Yeah, that will do. Thank you. Okay, so let's resume with the practical session. We will start from the very basic again. I want you to have an idea, you know, about the universal goniometer. So what you can do, you can place this over here, okay, or over here as well, and then you can set this like this, and you can measure the angle. Okay, so in my case it has to be actually like this. It should be set to the level and then to the triggers, and it's about, it's almost 50 degrees in my particular case, in my subject. So anywhere between 45 to 55 is considered to be the normal. So this is for the forward head position. You can also perform an occipital to wall distance test, and then, like I was saying, you can ask your patient to perform the active flexion, active extension, and side bending and rotation. So you need to see how the vertebrae are moving and what is the position of the vertebra relative to each other. Then you can make use of this device, which is called as an algometer. Now this algometer is actually measuring the force. So right now we can change the units to kilograms, and we will see, if I press, you can see over here, if I press, there is a change in the force. Okay, so let's set it to 0, and you can clearly see onto the screen that the force changes. So you can ask your patient to tell at what spinous process level when you are going to press. Let's show you like this. If I'm going to press it over here, let's say this is the point that has hypermobility, and you press it over here and the patient says, okay, I feel pain. So you can read this reading, and you can mark this at, let's say, at this particular level, at C3 or C4 or C5 or C6, 7, whatever is the level. You can find out that this is right now the uh, threshold or the pain pressure tolerance or the springing force tolerance for this patient or for this vertebra. Okay, so you can measure or document this for your research as well. So after that, you can also definitely go for a bubble inclinometer. You can just set this dial to 0, and it should be placed on top of your subject's head, and then you can start moving. So the thing is, you set it to 0. Here I can show you like this. So you set it to 0. I'm not sure if it is at 0 right now or not, but this should be placed on top of the head. As soon as the patient moves, you can see that the water level drops, and you read the inner readings for the flexion and extension, side bending and rotation as well. For the side bending, it should be placed like this. For example, I want you to turn. So the dial should be towards me, but right now I'm showing it to you. It should be like this, and you can go for side bendings. Okay. So after the goniometry or the inclinometry, you can go for the palpation. Now palpation is quite easy. I was saying you need to go to the external occipital protuberance, and from there you need to come down. So as you can see, you get into a soft tissue area where there is only soft tissue. No matter how hard you can press, there is no palpation because the C1 does not have any spinous process. So the first spinous process that you are going to palpate is C2 actually. So to make it even more prominent, what you can do is you can ask the subject to go into the movement of flexion. So they go into the movement of flexion,
and then you palpate. So the first spinous process that we palpate is C2. Okay, so from there you go to C3, then you go to C4, then you go to C5, then you go to C6, and then you go to C7. And at the C7, like I've told you, it was the vertebra prominence. So the vertebra prominence is, it will be moving. Can you please perform movement? So here you see this is C7. I want you to go back, go into flexion, and the with maximum flexion you will see this coming out. This is C7. Okay, so from C2 to C7 you palpate all the spinous processes. And coming to the transverse process, just below the mastoid process, you see this is a muscle that is called as sternocleidomastoid. So from the mastoid process you go down all the way, and then you are going to palpate. These are the transverse processes of the cervical spine. So transverse processes can be palpated. They are deep actually, because there are these three muscles: anterior scalenoi, the middle scalenoi, and the posterior scalenoi. They are like this. So you can palpate. So sometimes what we do is we grab it like this and we squeeze, and we can also move it like this, and we feel if there is any movement restriction or not. So what we want to do exactly, what I can show you on this model as well. Here you can see these are the transverse processes. So we want the head to be moved onto one and the other side into side bendings, and we want to see if these transverse processes are moving or not. So these transverse processes, they should move. Okay, they should move with the movement of side bending. Now once we are done with this, we can of course look for the tenderness, we can look for the temperature differences, we can make use of a digital thermometer or a nervoscope, as well as we can feel for the tone in the muscles. And then we can, for the purpose of assessment, there is a test that is called as the VBI test, or vertebrobasilar artery test. So that is really very simple. You can do it in supine position. I'm doing it in sitting because I want to show you. So in that, you can first introduce the movement of flexion, side bending, and rotation to the same side. For 30 seconds, you need to maintain this position. If there's a problem, if there's diplopia, if there is any blurred vision, if there is any dysphagia, if there is any blackout, syncope, or loss of balance, or vertigo, or dizziness, there are 5 Ds in it. So then it means that it is positive on this side. Then you can also perform the movement of flexion, side bending, and rotation to the opposite side to test the other side. As well as you can do this test into the position of extension, side bending, and rotation, as well as into side bending to one side with rotation to the other side, if you are not sure about the vertebral artery. Okay, so in flexion, side bending and rotation to the same side; in extension, side bending and rotation to the same side, as well as to the opposite side. Okay, once you're done with these tests and you have already screened the patient for the vertebral artery insufficiency, it's fine, like it's not abnormal, then what you can do, you can go for a passive testing. That passive testing involves you to passively move the spinous processes anteriorly. We just want to press them into the anterior direction to see if there's any restriction or not. So how I'm going to do this, I'm going to place my bicep against his head, and I'm going to cradle his head like this. So from here, I want to use my thumb, and at any given spinous process, I'm going to move forward. Right now, if I press this, the patient or the subject will feel pain, and it's a lot hypomobile. And this is actually C2. This is upper cervical spine. Today, I'm not going to tell you how to fix the upper cervical spine. Rather, I'll be talking about how to fix the lower cervical spine and the cervical thoracic junction. Okay. So similarly, you can go down and down and down. You will keep on pressing, and you will mark those points that, okay, the problem is at C2, C3, C4, C5, whatsoever, and definitely the patient will be having hypomobility. All right. Once we are done with these things, we can ask the patient to go prone first. Okay. I want you to lie prone, please. And let us fix it like this. So I can have an idea. उतार दो, कोई बात नहीं. I want to, let's put it aside and let's keep it like this. Okay. Okay, there you go. So for the patient's convenience, what you can do is you need to place a towel just below their head. Why I'm placing this towel? Because I want my patient to be comfortable. So yeah, so there will be no mark on the forehead. The patient is relaxed and comfortable, and we always start from the cervicothoracic junction. What I'm doing over here, let us adjust the camera a bit, or maybe I can place it the other way around. How about I place it like this? Is it? No, the other one is better. This view is even better. Yeah, this is better because they can see what's going on. Okay, so technically I'm a right-hander therapist. I should be standing at the right side of the patient, and what I'm doing, I'm just pressing it down. I'm pressing it down and I'm trying to feel if there is any restriction to the motion. When I press down, I'm just trying to see for the restriction, okay? And I want to see if there's any problem in the muscles or not. So the perispinal muscles are good and fine. There is some restriction at this point as well as, and there is one more thing. You can use, this is called as contact thumb and this is called the reinforcement thumb. So contact thumb is at any spine process, and then reinforcement thumb is, so you can see I am pressing it down at different levels and the patient will have hypomobility and pain. Okay, it's similar to this. For example, you can see this. So contact thumb, and then this is not applying force, but the reinforcement thumb is applying force. Then what you can do, you can come onto the top and you can move into movement of side bending. So let me show you if I can from here. It's going to be this phenomena. Okay, so once everything is fine and clear, now let's come to the manipulation of cervicothoracic junction first. So for the cervicothoracic junction, our patients are in prone position. I want you to hear the pop as well. So I'm going to place the microphone over his head, and the position is pretty simple like this. So the shoulders are abducted to 90 degrees and the spine process is like this. We can also remove the, yeah, that's even better. So from here, actually I had to be on that side. So, but let's keep this in this perspective. Okay, if I want to manipulate from this side, I'm going to take a contact using the PZ form of my right hand towards the right side of the patient, and I'm going to rotate the head into the opposite direction, and then at a particular point where I feel the restriction, I'm going to give a thrust. So let's see if we can create a thrust, relax, and there we go. So this is the popping of C7 and T1. So to the other side, if I've been doing this from the top side, it could have been, I don't want to block the view, but it could have been like this actually. So relax, I want you to relax, relax to the point of restriction. I believe, no, you guys can. So to the point of restriction, you see, and at this particular point, even I want to share another view. So to the point of restriction, I'm going to give another thrust, and that's it. So for the cervicothoracic junction, what I'm doing, I want you to see, I'm going to repeat it again. Okay, so the thing is, If I want to cavitate cervicothoracic junction, this is called, which rotation is this? Right rotation. Okay, Osama, right?
Right.
This is right rotation. So with right rotation, I'm going to move the C7 and T1 junction, actually the T1 in the right direction and head into the left direction actually, and the head into right direction, and there is the thrust. And similarly to the other side, it's going to be like this. Okay, so I'll be waiting for your feedback. I want you to tell me if everything's fine or not. Is it okay? Is it fine? Or if there's any question. Okay, so let's see how can we manipulate or cavitate the lower cervical spine. For the lower cervical spine, I want to tell you one thing, and that is really very simple. Never ever cavitate the spine in sitting position. Okay, especially if it is the cervical spine. So for the lower cervical spine, this is called as an up glide manipulation. So please, can you go supine? And okay, so now go there, go down, down, down. Now let's put it here, and let's change the view. Field of view should be different, so I want them to see from the bottom side. Osama, can we shift this? What I want is, I want that they should see. वो मैं सामने हूँगा. Actually, it should be on from the top actually. So let's see if we can increase the height. And no, and from the top we can maybe place it over the couch as well. Maybe this is more like it. Yeah, Dr. Osama, can we keep it like this? No, we cannot, I think. Yes,
Yes.
we cannot.
Uh,
Can we place it? This will be really very good. Can you put it down, down, down? Let's, we are trying our level best. Yeah, this will be really nice for you guys to see. This is the best view I can give you right now. Okay, so I've been doing my best. Now I'm going to sit because of the view. Okay, so here you can see, and I can also see. Right now I am sitting next to my patient and his cervical spine is relaxed. So what I want to do is I want to press against the spine's processes upward, okay, towards the ceiling. So I want you to relax. See, when I press up with my fingers, I'm just trying to move each spine's process up. It's just like this. I want you to see. So from bottom, I'm contacting with the fingers. I want to move them anteriorly, just like they go into the flexion. Okay. So up, up, and up. So at this particular point, I need to feel for any restriction in the range of motion, as well as I can move. This was the test I was trying to tell you. I can move into different directions, and I can move into flexion, side bending, and rotation to see if there's any restriction or not. Okay. So once we have identified the vertebrae, this is very important. Like I've told you, from the mastoid process, these are the transverse processes. If we draw a line at the transverse processes, my hand, this part of my hand actually, the metacarpophalangeal joint, this is going to make a contact posterior to the transverse processes. Okay, just like this. So this is very simple to do. We are going to use two levers, and the levers are side bending and rotation. So like I've told you, side bending to one side with rotation to the opposite side is coupled motion for the upper cervical spine. To cavitate the lower cervical spine, we do the same. So we go there, we go into the side bending, okay, and from the side bending, let me put this next to you so you guys can also listen the pop. Okay, so go to the side bending. Now this side bending should be based upon the motion segment. If it is the, let's say, C3, we need less side bending. If it is C4, we need more side bending. If it is C5, C6, C7, we need the maximum side bending. So this is the first lever. Okay, and then let's say we go into the mid position, side bending, and now we are going to rotate to the other side. So it's purely two movements combined: side bending to one side and rotation to the opposite side. I'm doing it again slowly in front of you guys so you can have a better idea or understanding that side bending to one side and rotation to the opposite side. At this particular point, I need to move this into a curvilinear pattern to cavitate, and you can listen the popping sound. So let's do it. There it is. So you go and you give a drive. So now to the opposite side, let's see. We can plug this over here. Side bending to one side, okay? Rotation to the other side. We can also add movement of flexion and extension depending upon the patient's condition. And then relax. I want you to relax, please. Yes, relax, relax. Feel the barrier, and at that point, you are going to give a thrust. So again, relax, and there you go. So we cavitated his cervical spine from both sides. Now we will watch the very same video again, and we will see what was wrong in that video. So we are using two levers: the lever of side bending and rotation on opposite sides. So that's how we actually treat, or we fix the cervical spine and we do the manipulation. This is for the lower cervical spine, and this particular technique is called as an up glide manipulation. I hope everything is clear, and if you have any questions and comments, you can ask me. The last 10 to 12 minutes are going to be a question and answer session. If there's any ambiguity, if there's any problem, we can discuss. So I'm turning this off right now, and I'll be switching to the laptop camera to have a question and answer session with you guys. I hope you enjoyed it. Thank you. Let's just put it this away. We are going to fix this again later once we are free. Okay. अच्छा सब तो पैसे मिलने चाहिए यार सेशन भी okay, we are still live. Okay, so let me see if I can, yeah guys, this is me, your instructor. So please, if you have any questions and comments, I'll be waiting for your comments, questions, feedback, anything you want. I'm here to discuss. If there is any point, if there's anything you want to share, you want to ask, you are free from my side. So just waiting, okay? So my session is done from my side. I believe you will be having a lot of questions, a lot of ambiguities. These techniques, they need to be taught physically, and they require some background knowledge, some practical sessions and repetitions. No. This is the whole point. This is the whole point. If you recall, in the start, I've shown you the video. If we go for the rotational manipulation, we are going to cause damage to the artery. We don't want to do that. So never ever do that. This is the whole point of this presentation and practical aspect. We don't want to cavitate in a single movement. We don't want to do any rotational manipulation. Anyone who claims to do that is actually doing it wrongly, and it's not a good technique. Now, I don't want to say that, just go to them and tell them. Of course, you can tell them if they are willing to accept what I'm saying, because this is the most sophisticated way of doing things. We can say that this procedure has the minimum risk involved, The rotational manipulation has a lot of risks involved. I've shown you the pictures, I've shown you the videos. You can also look for the venograms, and you can look for other studies as well. There are a lot of people who have died from such manipulations. So they are not safe, they're not good. Uniplane or uni lever techniques are not good, and I personally and my team, we do not encourage them, we discourage them, because those who know, they know. So it is because in Quran, Allah subhanahu wa ta'ala says that Kul hal yastawi allazina ya'lamuna wal lazina la ya'lamun. So those who knows and those who do not, they are not equal. So we have been, I've been representing the Manual Therapy Association of Pakistan for 5 years across many forums of the world. I've been delivering lectures, doing discussions, debates, and blah blah blah. But all of the guys, they are doing the same that I'm telling you. So we do not encourage these unilever or uni-axial or uniplanar techniques. Okay, that's. No, it's a very good question. Someone asked, as you asked, cervical spine manipulation only applied in supine position, not in sitting. It is totally restricted position for manipulation. No, it is not totally restricted, but like for example, if someone is, let's say, is phobic, they have phobia or whatsoever, then what happens? Of course, it means that they will faint out, and the patient is not stable. So we always choose the most stable position for our patients. Okay, this technique or method manipulation was of cervical spine as a whole or segmental. It is segmental. Number one, Dr. Mohsen PT, it is segmental. It can be applied as a whole as well. If the thrust is too much, then this is only for the lower cervical spine. Okay, this does not work for the thoracic spine, this does not work for the lumbar spine, and definitely it does not work for the upper cervical spine. If you have any other question, feel free, I'm all yours. So I think that's all from my side. Maybe you guys don't have any questions, and thank you very much for being such a nice audience, and thanks a lot to all the people, especially Dr. Nosheen and Dr. Zainab from UMT. They have you know been, you can say, a very important person in whole of this scenario. So they were responsible for this webinar or lecture, and thank you so much for your time.
And what about the
And what nah. Okay, so for the upper cervical spine, we need to be very much careful. Why I'm saying this? Because this is the point where the vertebral artery is becoming the basilar artery. So you need three levers for that. Okay, the lever of flexion and extension, the lever of side bending, and the lever of rotation as well. And you need to have a very good manipulative skills. I can do it. You can find my videos on YouTube and Facebook, a lot of videos, but I don't want you to do it on day one. I want you to keep on doing the lower cervical spine, the thoracic and the lumbar spine manipulation, even the SI joint manipulation, for maybe up to 6 months. And after that, you'll start to gain the confidence. You'll start to feel the joint and the ligaments and the muscles. So once you are competent enough, and once you have been trained enough, then you can go for the upper cervical spine. So from my side, I always tell my students, don't try to cavitate. The risks and the benefits, always try to compare these. And most importantly, we don't want to create a crackling sound only. Okay, this is important. The argument is, we do want to cavitate, we do want to manipulate, we do want to adjust, but not at the cost of a side effect, not at the cost of a bad event. Okay, so we want to do these things only if they are safe and if they are beneficial to our patients and our subjects. We don't want to do them if there's more harm than benefit. And I believe that's all from my side.
thank you.
Thank you very much for all of you guys. It's been long 2 hours, and I believe you have learned something new. I'll be waiting for your questions and comments. You can definitely contact my WhatsApp, my website, my Facebook, my YouTube, any way you want. Thanks a million once again. Stay blessed. Khuda Hafiz.